Okay, so we're going to get started here. So I'm Dr. Ben Weitz, and welcome to the Functional Medicine Discussion Group meeting on female hormones. I'm happy to see that we have some new faces tonight, and I really want these meetings to be participatory, so please ask questions, get involved, and I hope that everybody can share your ideas and experiences. And these meetings are really about bringing the functional medicine community together so we can share information and experiences so that we can better help our patients. Also, please join the closed Facebook page, Functional Medicine Discussion Group of Santa Monica. And also, please check out my Rational Wellness podcast on iTunes and YouTube. And I want to start by thanking Metagenics for providing some awesome food for us and for being our sponsor. So I'm going to introduce the topic, and then I'll introduce our guest speakers, and then we'll get started with our question and answer format. And so anybody who wants to ask a question, Diane is going to have a microphone just to make sure that everybody else can hear your question. So our topic for tonight is female hormones. And both our guest doctors are proponents of bioidentical hormone replacement therapy. I don't know how far to keep this microphone from my mouth to actually pick up and not have it be too loud. So anyway, for those of you who are not familiar with this topic, I'm going to shed a little history on the topic of hormone replacement therapy. I'm sure for a lot of you, this is common knowledge. Anyway, for more than 60 years, women have been treated with Premarin, which is estrogen from horses, or with Prempro, which is equine estrogen plus synthetic progestin. It was prescribed for menopausal symptoms like hot flashes, night sweats, mood swings, insomnia, and it was thought that it would reduce heart disease in women, and it was widely believed that the reason why women had a lower rate of heart disease was because of estrogen. And then in the 90s, there started to be concern about estrogen-related cancers like breast cancer with estrogen replacement. But there were no alternatives for hot flashes and vaginal dryness and the other menopausal symptoms. And then in 2002, a nuclear bomb exploded on the hormone replacement party with the publication of the Women's Health Initiative trial, which showed that not only did hormone replacement increase the risk of heart attack, stroke, blood clots, and breast cancer, and the sale of Prempro crashed more dramatically than if Donald Trump had been tweeting about it. That's my joke for the evening. And the Women's Health Initiative was a massive study with over 160,000 women, and that gave this study a lot of prominence because very few studies involve that many subjects. And since then, there have been quite a number of reanalyses of this trial, and one of the flaws of this trial was that the women were given hormone replacement a number of years into menopause. And so it turns out that when you start hormone replacement in perimenopause or closer to the beginning of menopause, it lowers the risk some. And today, many functional medicine doctors, like Dr. Carragher and Dr. Stocker, use bioidentical hormones, which are believed to be safer. However, there have been no large-scale studies done on them. And this is probably partially because you cannot patent hormones, and so bioidentical hormones cannot be patented, whereas synthetic ones can. So there's no interest from the drug companies. And so right now we have a real quandary as to, at least in part of the medical community, about whether it's a good idea to use hormone replacement or not. And in 2012, the U.S. Preventative Task Force concluded that the harmful effects of combined estrogen and progestin are likely to exceed the chronic disease prevention benefits in most women. On the other hand, a consensus expert opinion was published in the Endocrine Society stated that when taken during perimenopause or the initial years of menopause, hormonal therapy carries significantly fewer risks than previously published and reduces all-cause mortality in most patient scenarios. So now let me introduce our speakers to help us sort out this controversy and to provide some advice on whether we should and how to prescribe female hormones to women. So Dr. Jill Stocker completed her undergraduate training in molecular and cellular biology at the University of Arizona. She went on to medical school at the Kirksville College of Osteopathic Medicine in Missouri. She is board certified in family medicine and has an advanced certification in age management medicine. Dr. Stocker specializes in age management medicine and hormonal optimization, and she has made it her life's work to help women regain their sense of self, juiciness, and vitality. Dr. Mike Carragher is board certified in family medicine with advanced certification in age management medicine. He received this training at NYU, at Rutgers University, at Yale University, and at Western University of Health Sciences. Dr. Carragher worked as an emergency room physician while starting his own private practice. He has been in private practice since 2002. He opened his current office in Hollywood, the Body Well, in 2007, as part of his vision to provide the highest quality health care with a strong emphasis on prevention and wellness. He addresses age management from a 4 cornerstones approach: hormonal optimization, nutrition and nutraceuticals, intelligent physical fitness, and mental ability and emotional well-being. Thank you, Dr. Stocker and Dr. Carragher, for joining us. So I'm going to ask the first question, and then hopefully everybody can jump in and participate in the discussion. So the first question I have for both of you is, do we really know if bioidentical hormones are safer? And is it really a good idea for a 60-year-old woman to have the estrogen levels of a 30-year-old?
Sure. Hello, can you hear me?
Yes.
Hi, thank you for having me. I'm very excited to be here. He went through the whole history of, of hormones in general, and I actually kind of lived that in my training. I came out of residency right after I had been telling women how great hormones were, and then we had this huge study saying they're not so great, so I had to take all of these women off of their hormones, which was very tough to do because it really affected their quality of life. It really made us question the healthcare system in general. Well, what you were telling me that this was healthy and good for me, and now it's not so good, and I don't feel good. And we were left with treating women with antidepressants to treat their hot flashes and mood swings and night sweats. And that just led to a whole whirlwind of bad side effects. Weight gain, which then increases your risk for diabetes, high blood pressure, just a whole slew of side effects with the antidepressants. And then we learned about the different arms of the Women's Health Initiative and what the real truth was about it, and got more information as far as which estrogens were being used. And the comment that you made earlier is, you know, we were using horse estrogen. Why would women need horse estrogen? I don't know who thought that was a good idea in the first place. And so all those studies were based on that, all of the bad studies. So now, fast forward, we have more studies showing that estradiol, or natural estrogen, is actually healthy for women and actually does reduce the risk for heart disease, cancer, osteoporosis, Alzheimer's disease. But again, knowing the different forms is very important. And as you also had mentioned about, it's important the time frame that you start a woman on hormones before they actually develop any type of plaque formation. So that's kind of a tricky subject. And the question that you had asked as far as, is this a good idea? Having gone through that experience of having to take women off of their hormones and they were feeling great to having them crash and not feeling great, I literally have had women in my office say, you know what, I don't care if I am going to have 5 years cut off of my life because I'm taking these. I want to have a life. I want to have a quality of life. I want to be able to spend time with my family, watch my grandkids grow up. I want to, be intimate with my husband, partner. And so to answer your question, yes, I think it's a good idea to give women their quality of life back. And with regard to the safety, you also had mentioned there's not a lot of studies out there with bioidentical hormones. There's not a lot of publicized in the general media studies. There are a lot of studies out there regarding bioidentical hormones and how safe they really are. But as you had mentioned, there's not a lot of money that's put into the drug companies promoting it. So there's not a lot of information that the media would be very excited to look into. So I don't want to hog the microphone. So.
Thank you. And thanks, Ben, for having me here. And hi, everybody. I'm glad you came out. To get right to it, hormones get such a bad rap, you say hormone replacement to a lot of women, the first thing that they think is cancer, right? And rightfully so. I mean, it has been that fear has been stricken in them by the media, and when the truth of the matter is that if you use the right forms of hormones in women, you will decrease their breast cancer risk. You will decrease their endometrial cancer risk. Bioidentical progesterone decreases, it's an apoptotic to cancer cells. It's apoptotic to breast cancer cells. It decreases breast cancer risk. It decreases endometrial cancer risk. The Women's Health Initiative, now that we're years out for it, and that data has been pulled apart and teased out, even Premarin, the conjugated equine estrogen, even Premarin, if that were the only estrogen around, I would give it to my mom, who's 78 years old, because in my opinion, the benefits of it outweigh the risks. The increased cardiac event risk, when they really look at the data, the population of women that were taking that, were, I think something like 40% of them were smokers. These were at-risk women. The reason that Premarin increased cardiovascular risk is because it activates a protein called matrix metalloproteinase, and which is an enzyme that causes plaque to rupture. Okay, and that increase in that enzyme is only in the first year of women on oral estrogen, and that's whether it's estradiol or whether it's Premarin. And but after that, it actually decreases cardiovascular risk significantly. Okay, and so if you want to be on the safe side, okay, in prescribing estrogen to women, give them estrogen cream. Okay, it doesn't activate matrix metalloproteinase. And they will get a lot of the benefits of estrogen. In my opinion, they won't get the protective effects that estradiol gives them over the long term. Okay, but they will get a lot of the other benefits. And the benefits of replacing hormones and keeping healthy hormone levels in women. bioidentical estrogen, and most of the European studies use estradiol. They don't use Premarin. So if you look at the European studies, the large European studies, they use estradiol. So there actually is lots of data out there on estradiol. And, excuse me, and estrogen builds bone in women. I watch bone densities improve over the years in my women who are on female. They will stop losing bone on estrogen. Bisphosphonates don't do that. Estrogen actually activates a protein in the brain that forget the name of it now, but it stops the formation of Alzheimer's plaques. Okay, so estrogen. You put women on estrogen replacement have a 50% decrease incidence of Alzheimer's disease. I mean, if that were a pill, everybody in the country would be on it. But we've got this fear around hormones, but the research is really there, and that's a starting point. I was joking the other day. I was thinking I'm going to start having my patients, sign a consent not to treat if they decide to go off the hormones, of all the things that are going to happen to them, So I hope that partially answered your question.
Good. So what do you think is the most effective way to test for hormones? Serum, urine, saliva, we have dry urine.
Yeah. Personally, I like serum testing, and mainly because most of the studies, everything I do is evidence-based. Every prescription that I give a woman or a man, for that matter, there's research there to back it. I don't prescribe things based on theoretical suppositions or what might happen by looking at some hormone flowchart. But I like serum testing because most of the research studies look at serum levels.
Is saliva better for monitoring women taking topical hormones?
No, it's interestingly, no. There have been a couple of studies done that show that salivary testing, you may have salivary levels that are in the normal range, but if you biopsy a uterus, they are not achieving adequate tissue levels of a hormone, even though their saliva tests come back normal. So that's the reason I don't use saliva testing, with the exception of cortisol. I think that's because it won't do like
four-part cortisol.
Yeah.
I think the important thing also to note is I do follow serum tests as well. But the more important part is the person that's sitting in front of me that I'm treating, and they're telling me that they feel miserable. Because if that number on the paper is perfect, but they feel miserable, I'm going to treat that person. And the serum level is that just that. It's not actually a measurement of what's getting in the tissue or what's crossing the blood-brain barrier and actually, helping with any brain fog they have. So. I do monitor that. The other thing is estrogen and progesterone levels will fluctuate drastically in the perimenopausal area time frame, and that can start as early as your 30s. And you definitely don't want to start some women on estrogen too early, because they will not like you. They will gain weight, get puffy, get moody, and I've seen fluctuations so like within 100 points of each other, just in a matter of like a couple weeks in women, and there's no way I would treat them with that. The other thing is you do get conversion of testosterone to estrogen, and testosterone is actually a game changer for women, and I think we really get focused in hormone replacement therapy on estrogen and progesterone are just like the only things, because that's what the media has talked about. But testosterone, or low T, is not just a man's disease. We need it as well. And lots of questions. Yes?
She's going to bring up microphone.
Hi.
You got to hold it close to your mouth.
Okay. Hi, I'm Howard Elkin. I'm a cardiologist, but I've been doing anti-aging medicine for about 17 years. Anyway, so I started doing using bioidentical hormones before actually the Women's Health Initiative came out, and then it just sounded right to me. But then I got educated on it and learned a lot more through my fellowship. So I use serum personally at the beginning just to prove that this woman has no hormones. Once I put them on Bioidentical HRT, I've tried everything, serum, saliva, but I really like the 24-hour urine. It tells me what the metabolites. It also tells me specifically how they metabolize their estrogen. The 2-hydroxy, 4-16-hydroxy, it's a big difference as far as those are the things that it's pretty important. Also tells us how they methylate. So I enjoy. I mean, to me, it's work. You have to explain it to the patient. But when I do serum levels, and I do them occasionally, I'll get progesterone levels of like negligible. The quest, just negligible. When they're taking like 150 milligrams of progesterone, so I have found just serum levels once they're on HRT to not be very effective in my practice. But I've done saliva. Saliva can be really crazy. It can be normal. It can be off the wall. That's just my observation. But with at least with the urine, I can make sense out of it, and I can put them in appropriate supplements, depending on what I find, and it's going to be really helpful, and I do it on a yearly basis.
How many people in this room prescribe bioidentical hormones? See, show of hands. I'm curious, how does everybody else test, and what testing do you find most effective?
If somebody's on pill form, I use blood because it's being conjugated in the liver and it's bound to a protein. If they're on a cream, I use salivary because you're getting a different, creams aren't getting balanced, so they're not going to show up in the blood. And you'll get very different readings on the two, but they're showing different things. One is the bound and one is the not. So that's mostly how I do it.
Have you tried the dried urine, the Dutch testing?
I have not. I was educated not in that direction. So.
Yeah, it's a newer strategy.
Can you explain what that is? I don't know what it is.
Well, basically, you can measure, you take these little sticks and you stick it in the urine so that you get dried urine, and you can measure urine hormone levels, and you can do it at different times a day.
Well, my question is, it's something I've been curious about, is in Europe and Canada, they use a lot of estriol hormone replacement rather than estradiol. And my understanding of menopause is that it's a natural transition, right? A woman who is healthy and vital and balanced and whose adrenals are in good shape, which you don't find a lot of here. They're going to convert androstenedione into estrone, and so we become estrone dominant instead of estradiol dominant. And I have my opinion about why keeping people estradiol dominant may not be, from a psycho-emotional perspective of how a woman develops, the best thing. But that said, I'm really curious about why Europe uses estriol instead of estradiol, and why we use estradiol here. And my understanding is that studies show that estradiol really has no negative, there's no controversy, no negative side effects, and yet we still stay really focused on estradiol here. I'm wondering if either of you have read about that or know anything about that in this future.
Yeah, I don't know. I know that most of the big European studies have used estradiol, as the study form, oral for that matter too, not topical. But I don't know what what the reason is behind Yeah. I mean, I know.
Isn't estriol considered a weaker estrogen, and therefore the thought is that it's safer?
Yes, the thought is that it's safer. I've never seen very much research to back that. So again, I make my recommendations based on what's been put in the research.
Thank you.
Yeah, thank you.
Any other questions? We have other questions? Let's see. So when you first work with a patient who comes in who's having some of the symptoms related to, potentially related to, estrogen deficiency, do you work with them on a nutritional and lifestyle program as part of their overall program? And do you use diet and maybe supplements first, or do you start with hormones, or do you do them at the same time?
Yeah. I attack it from all angles, but I do it in a stepwise fashion because I found that if I have a woman that comes to me and she just doesn't feel good and she doesn't feel motivated, if I throw her all this information and regimen to do as far as nutrition and fitness, she's going to feel like she's failed before she even started. So correcting that hormonal component first is really key, and I generally will see results within the first week to 2 weeks of they're sleeping better, they have more energy, they just feel better, they feel more motivated, and then they absorb that information a little bit better. So I kind of give them little homework things to do the first week or so, like 2 or 3 things that are super simple for them to do, because then it's not so overwhelming. But then I do address the reason why we recommend certain dietary regimens, which it's not a diet that anybody's placed on, but just explaining the role inflammation plays. And inflammation starts in the gut. So anything we put into our mouth that we digest causes a response. If we have inflammation in our gut, then we get what we call a leaky gut, and we're not absorbing our nutrients, our hormones, and our vitamins. So I really try to talk to people about getting their bodies to work for themselves, because then they'll need less of the external hormones. They'll actually absorb the ones that they're already making. And then I also do talk to them about fitness, because there is the hormonal recruitment of exercise, where you actually do stimulate your own testosterone and growth hormone production, which are also, like I said, very important other hormones instead of just the estrogen and progesterone. So all of those things together really create a great, the optimal result. I also talk to them about certain lifestyle modifications as far as meditation and getting good sleep, lowering their cortisol levels with that. So, but like I said, I do it in a stepwise approach so they don't feel so overwhelmed.
How about the woman who comes to you, she's in perimenopause and she's starting to get some of the symptoms, and she says, look, I don't want to do hormones. Do you have a protocol for her? Do you have certain nutritional supplements you like to use? How would you approach that?
Well, I try and find out what her concerns are about the hormones. Most people, their big concern is cancer. The other thing is, I'm going to gain weight. And the reality is, if your hormones are not optimized, you're having difficulty losing weight. And so the minute that myth is dispelled, they're like, oh, okay. So I find out what their concern is about the hormones. And if it's one particular hormone, there's, 5 other ones that I can optimize. So if they don't want to be on estrogen, that's okay. I can talk to them about different options, and we can optimize the other hormones that they're comfortable with.
Like what?
Like thyroid. Thyroid is huge. It's our metabolism. It affects our weight, our energy, mental clarity, people that have brain fog. It can affect your hair, skin, nails. And the biggest concern that I have people come in with is lack of energy, which can be from thyroid, testosterone, growth hormone. So like I said, if they have just a concern about estrogen, there's 5 other hormones that I can optimize.
So what's your ideal thyroid panel, and what level of TSH are you most concerned about intervening at?
So we use the same panel basically, right? So I'll test a TSH level, a free T3, which is the most active form of thyroid hormone, and a free T4. And then based upon that and their symptoms, I will prescribe.
Do you measure antibodies?
No, and then not unless I have some, suspicion about some
reverse
or
T3,
something like that. No. That's not a hard and fast no, though. My initial panel I don't. Usually what in the majority of patients, the thyroid's super interesting. you know, I'll have tons of patients that will come to see me. They're either on Synthroid or they're on thyroid replacement like Armour, Nature Throid, or whatever, and they're still having low thyroid symptoms, right? You know, their energy is still low, and they're you know, they're gaining weight. They're, you know, have hair loss. Their mood is depressed. You know, and you know, these symptoms are kind of general symptoms that can be attributed to so many different things, right? You know, I mean, is it their thyroid? Is it low testosterone? You know, are they depressed? Or they have some other sort of metabolic thing going on? Is there, you know, they have leaky gut? And so, you know, I fix what I can see is broken, but dive a little bit deeper into thyroid. There are a lot of places along the chain that thyroid can go wrong. You know, I mean, you know, you have the thyroid hormone, which produces T4. T4 has to get converted to T3, right? If they're on Synthroid, which is T4, which is what most, you know, physicians prescribe, they'll get Synthroid, they'll send a message back to the pituitary telling them that they've got enough T4, their TSH will normalize. This is the scenario that we see most of the time when patients say, oh, my doctor checked my thyroid, he said it's normal. Usually he's just checking their TSH and it's normal, right? It's such little information. I don't even know why we still test that. You know, they're making the assumption that if they're giving T4, that it's converting to T3, right, which is the most active form of thyroid hormone. Well, a lot of times you have an enzymatic problem. You don't have enough of the enzymes that's converting T4 to T3, or you have receptor level resistance to T3, right? Just like we have insulin resistance, we can have thyroid resistance as well. And so you have patients who are taking normal doses or even higher doses of even, you know, Armour or T3, but they, you know, they're still not feeling better because they have receptor level resistance and they just need higher dosages, you know? And so, you know, I'm not afraid to suppress the TSH level down to 0.00 whatever, you know, and have a T3 level that may be, you know, 4, 5, 6, 7 if the patient's feeling well. You know, psychiatrists use very high doses of T3 to treat, you know, mental illness and depression, and they never check levels. You know, they just treat it symptomatically, and you know. Primary physicians will freak out and, you know, tell you you're going to get osteoporosis, and you know, if you're you have all of these negative things happen as a result of having your TSH suppressed. But they're confusing that with Graves' disease, which is an autoimmune disease that has, you know, other sequelae like that are different from just replacing thyroid with synthetic thyroid.
One thing that you had mentioned was as far as the changing in the doses and how it does affect, is affected by the adrenals, is another thing that somebody had touched on earlier. Early in my training, one of my mentors actually specialized in adrenal fatigue, and one of the studies that I had seen was that when you have adrenal fatigue, your thyroid receptors are 50% less responsive. So when people say, like, why does my dose keep changing? You know, why am I not going to be on the same dose for 10 years? You know, well, you're going to have, as we age, our hormones are declining every single day, so you're not ever going to be on the same dose. But as you have any type of stressors, you're not sleeping well, and you're getting into any type of adrenal fatigue, that's when you'll also not absorb this. You'll be taking the same amount or need higher and higher amounts, and it's still just not receiving that. So optimizing the adrenals is also.
What is your preferred method for optimizing the adrenals?
I really try to focus on lifestyle modifications first. I do use hydrocortisone or Cortef on occasion, but really trying to get them to sleep better, to reduce their stress by whether it's doing meditation, yoga, doing one less thing instead of one more thing on their to-do list every day, just really working on those things, and that can make a huge difference.
What about somebody who has a cortisol curve that is lower in the morning and goes up in the evening? Are there certain supplements that you'll use to try to control that?
I've used ashwagandha before, and that seems to work really well. I have seen some people that, and that actually, most people that I've recommended it on, it actually made them a little bit sleepy, so I had them take it at night. So it was kind of rebooting in general. And 5-HTP as well.
How I've done it, because I do a lot of adrenal testing, because they say in anti-aging medicine, really, you have to treat the adrenals on both first before you look at the thyroid, because they're so interrelated. Because the symptoms are the same: fatigue, weight gain. I mean, and it's really menopause, adrenal fatigue, and low thyroid. They overlap the symptoms. So what I do check a lot of adrenals, and if they're flatline, and sometimes really a flat line, and they can barely move, then I will use hydrocortisone initially. Because it takes a few months for the adaptogens to work. I found it takes really for optimal, like 6 to 9. It does not work overnight, so I use that, and then along with the adaptogens, and then eventually try to get them off hydrocortisone.
What are your favorite adaptogens for low cortisol? Do you use licorice root or what?
What I use?
Yeah,
Combinations of.
especially when they're low cortisol.
Yeah. I have actually a product that I actually use that I put together. Actually, remember I have a few products. Ashwagandha, one of the ginsengs, and because really looking for its balance. The only time I would not use it if someone's like hypercortisol, then we use like phosphatidylserine or something like that. But most of the people that I see, by the time I see them, are in stage 2 and 3. I rarely get to stage 1s. They've had adrenal dysfunction for so long that I get them when they're stage 2 and 3.
I'm just curious what doses of Cortef you use.
I really use low, like 10 milligrams in the morning and 5 milligrams. But usually I try to use it before 2 p.m. because it can really keep up at night. Yeah. So it's relatively low dose. Yeah. And I don't think I've ever had to go above that. And they feel better within like days. As opposed to the adaptogens, it can take forever to work, a while to work.
I try to keep it at 10 twice a day or lower,
Yeah,
just
something
sort
like
of
that. Really
permanently suppress the adrenals, But just another note on thyroid. Thyroid is also an excellent treatment for high cholesterol. It lowers LDL total cholesterol significantly. Typically at menopause or andropause, we see a flip in our lipids. Our LDL goes up and our HDL goes down. And optimizing hormones is one of the best treatments for hyperlipidemia. Certainly better than statins.
Because there might be a slightly increased risk of heart disease, or because there might be a slightly increased risk of breast cancer, are there any particular ways that you monitor your patients that you put on hormones, or are there any supplements or dietary approaches you might use, say, for somebody who's concerned about breast cancer, like, maybe use something like a indole 3-carbinol or a DIM to make sure they're properly metabolizing their estrogen, and make sure that they're pooping and that their detox system's working well, so they're excreting their estrogen and things like that.
Well, neither estradiol nor P4 bioidentical progesterone increase breast cancer risk, so I'm not concerned about that at all. As far as heart disease risk goes, that's really just with oral estrogen in a very high-risk patient. If I've got a patient who's an obese smoker, I'm not going to put her on oral estrogen, most likely. I will put her on estrogen cream, so there's not the activation of matrix metalloproteinase. She's not at increased risk for a cardiac event then, and so problem solved. She's going to need aggressive management of weight and lifestyle, and she's going to benefit from thyroid, estrogen, progesterone, testosterone, probably. Yeah.
But even if bioidentical estrogen doesn't increase your risk of breast cancer, there's still a potential for a woman to get breast cancer.
Sure.
The way she metabolizes her estrogen can be a factor.
The supplements that I like to use that help reduce overall risk of cancer, high-dose vitamin D. People really don't think enough of vitamin D, and the studies have actually shown it reduces your risk for cancer, heart attack, stroke, osteoporosis, depression. The other thing that
What do you consider high-dose vitamin D?
Well, the goal level that I shoot for is between 65 and 100. And according to the lab values, 35 is usually like the target or the high normal. But the studies have shown that between 65 and 100 is best. It also, high-dose vitamin D actually also boosts your own growth hormone production or your own IGF-1 production.
What do you consider high dose? Like how many units a day?
If they're really low, I generally give them a 2-week challenge of 50,000 units of vitamin D, and then I keep them on 5,000 IUs per day, and then recheck. And then the other thing that all of my clients are on, and I take myself, which is just a really up and coming thing. I'm sure you guys have seen it all over. Is turmeric or curcumin. A high dose of that reduces your risk for cancer. Heart attack, stroke, actually helps with blood pressure control. They've done studies with turmeric, high-dose turmeric and Prozac and Zoloft, and it actually worked better than those things. And obviously it doesn't have all the other negative side effects. So
I try to keep my patients somewhere close to 100 with their vitamin D levels, you know. I mean, you don't really need to worry about toxicity until it's well over 200, you know. So, you know, if you get back a vitamin D level that's 120, 130, or 140, don't freak out, you know. It's not an issue. Just have them, you know, stop taking it for a few months. It'll slowly come down, you know. But and yeah, I'm the same. Like if they're really low, if they're below 30, I'll give them 50,000 units, you know, a day for a couple of weeks, just to sort of boost them up. And then but after that, you know, most people do pretty well on 5,000 to 10,000 units daily. That'll maintain them up around there. You know, some people, just because they've got poor absorption, may require 15, but 5 or 10 is typically good. And we make sure it has vitamin K2 in it also.
I was just going to ask that. Yeah.
Yeah. The vitamin K2 ensures that, you know, so one of the main things that vitamin D does is it helps, you know, integrate calcium into your bone to maintain your bone density, right? And you want to have vitamin K2 at that so that your calcium ends up in your bones and not in your soft tissues where you don't want access calcium, like your coronary arteries. So,
which kind do you use? Because it's hard to find adequate, you know, 150 of MK7, K2 with combinations with vitamin. I have a product, but it's not 100. 150 is the dose that
I don't know. I've seen 50 as 50 micrograms as pretty. I think some of the studies were used 50. I think that's a decent level.
Smasher likes 150.
yeah. Well, I think ours has 50 micrograms also, yeah. And vitamin D3 we're talking about, not vitamin D2. You know, vitamin D comes in 2 forms, vitamin D2 and vitamin D3. If you go to your primary care doctor and he writes you a prescription for vitamin D and your insurance is going to pay for it, it's probably going to be vitamin D2, which is the poorly absorbed vitamin D. If it's like a little, you know, but you can go to, you know, you can go to Ralph's and get vitamin D3 for, you know, $5.99, and it's the better form.
I just wanted to comment on curcumin, because it's a Chinese herb, on the Chinese herbalist, and it's been used for thousands of years. And all herbs have a different effect on the body according to Chinese medicine. And curcumin happens to be bitter and cold. And bitter and cold, the bitter aspect of an herb can cause it to be drying to the body, and the cold aspect can be too cooling to the body. So curcumin is safe to use with somebody who's excessive and too much heat. You can look at their tongue, it's too red, they're running hot. But if you've got a frail, weak female who's in menopause and who's dried out, you start giving her a bunch of turmeric, you're going to dry her out more. And turmeric should be taken with, in Ayurvedic medicine, only if it's with black pepper, which helps moderate it a little bit. And classically, you know, they make those turmeric drinks, and in Indian cooking, turmeric is made with a lot of dairy. And if you don't want to do dairy, you can put it with other things that are moistening to help moderate the drying effect of it. But just taking super high doses of turmeric out of balance, and you've got a weak, you know, a frail, weak patient, you can further weaken them. So you do have to be careful with it. We tend in this country to kind of go to the research and look in isolation and go a bit crazy with it.
Really?
Yeah. And a little bit is good, a lot is better. And so the research will be looking in that isolation, but when you put it in the human body, it has an effect. And the effect of turmeric is it's heat clearing, and it's a detoxifier, and it's clearing, hence the reason it gets rid of inflammation. inflammation is usually from a bunch of toxins in our system, right? But you do have to be careful with dry people and cool people. That doesn't do
Oh, wow, thank you so much for that. That's really,
Which is
really
why
useful.
fish oil is so great, because you can't OD on it. You get it quality, but for anti-inflammatory.
Thank you.
I had a couple of questions. Can you comment on testosterone use in sort of women in their 20s and 30s? I see patients coming from other practices where you see testosterone pellets used, and these are younger women. And my second question is your thoughts on the Wiley protocol?
So testosterone in pellet form can be used in men and women, and it is generally a bioidentical testosterone that you make a small incision, usually in the side of the butt, and insert it in there, and it generally will last for anywhere from 3 to 6 months. So it slowly dissolves. I have used them in the past, and it's convenient for people, but it does leave scarring. And I've seen they tend to get a boost in their levels of energy and testosterone levels, and then it just slowly tapers off. So it's not very consistent. And the most recent studies have shown that it's just not very consistent. So I don't use those anymore. I mainly use the creams, the testosterone cream that you can put on the. It's really important to talk about if they have children and things like that, because you can transfer testosterone and cause ill effects with children. So if I have a younger woman that I need to put on testosterone and she has children, I usually will have her do injectable form, so there's no risk of transference with that.
What do you look for in terms of a 20-year-old? What symptoms are they complaining
It can be
about?
lack of energy, lack of muscle mass. They're working out the same as they've always been, and they're just not getting the gains that they were. Lack of sex drive, lack of ability to have an orgasm or the intensity of their orgasms. Yeah, go ahead.
Interestingly, so yeah, I mean, I think kind of part of your question is like, that's a really young age, right? It's like, do we need to be giving testosterone to women in their 20s, right? Interestingly, hormone levels, at least in men, I know that's have been declining with each subsequent generation. I think over the past 2 generations, testosterone levels in men have been 15% lower than the generation before. That's significant, and there's a lot of theories as to why that is, right? There's this whole idea about these things called endocrine disruptors, right? Which are, chemicals in the food supply, and phthalates, and plastic bottles, and cell phone radio, whatever it is, cell phone towers, and these things that screw with our receptors, and screw with our gonads, right? And result in low, low hormone levels. I was diagnosed with very low testosterone in the absence of any other pathology at 28 years old. I was had the testosterone of an 8-year-old. It was my total testosterone was less than 300. There's no other disease going on either, and so it's actually part of the reason that I got interested in this field of medicine. So again, it gets down to treating the patient. It's not just a level or a symptom. It's sort of like this story that starts to develop. And maybe there are other issues at play. Maybe there's been some chemical exposure, or something that is else that's at play, right? So. If a woman came in to see me in her late 20s and her testosterone was, and she had all the symptoms of low testosterone, and it was confirmed by lab tests, I would probably give her testosterone because she'd feel a lot better, However, that we might want to, try and explore environmentally or socially, whatever it is, other reasons that might be happening, and try and correct those as well, I have one patient who's in her mid-30s, and she's got like severe, chemical sensitivities. I mean, it's disabling to her life. I mean, like, she comes to the office, we have to make sure there's like, no air fresheners and no, like, she couldn't come because we had new carpet put in like for 6 months, and anyway, things like that. We live in this increasingly toxic world, right? And so there's a lot of unexplained mysteries out there now. Thanks for your question. Oh, we don't use it, no. It seems like a little bit of a one-size-fits-all, but and again, like, we're so, individualized with our protocols for our patients, that's just not something that I've ever really has appealed to me.
I'm curious about the thyroid question. Whether you're using Cytomel or Bioidentical T3, is there any feedback inhibition to the pituitary, or do you have to worry about inhibiting conversion from T4 to T3, depending upon how much of T3 you're giving?
So typically, and I'm glad you asked that question, because it just sort of changed the way that I've been doing things recently. I used to use Armour Thyroid, which is a combination of T4 and T3. We do need some T3, although it's the less biologically active form. We do need some T4. It crosses the blood-brain barriers. That's the form that gets into the brain adequately. Excuse me. Armour is a combination of T4 and T3. Recently, I think in the past 6 months maybe, or year, the manufacturers of Armour Thyroid, the pharmaceutical company that made it, was purchased by a large, big pharmaceutical company, whoever the manufacturers of Synthroid are, right? And with the effort to kind of drive it out of the market, and so they've like quadrupled the price of it. The price has gone up significantly, and not only did they buy the company, they bought the manufacturing plants in China also. And so a lot of people who had been taking thyroid or Armour for a long time aren't feeling as well, like, as they did, right? And so I've recently been switching most of them over to Nature Throid, there's also West Throid as well. That's my treatment of choice. And then additionally, if they've got chronic fatigue or fibromyalgia, T3 is such a great treatment for that. It really does relieve pain, and so I'll use TID or even QID 3 or 4 times a day dosing with T3 to help relieve those symptoms. That works quite well. And so I'll use a compounded T3 for patients, so I can really get the dose that works exactly for them, As far as feedback goes, typically if you stop a patient from taking thyroid products within a week, their TSH normalizes, or goes back where it was anyway, so, yeah.
I'm just wondering if their problem was conversion in the first place. Was it T4 to T3 conversion? Are you messing with that at all?
No, so you mean T4 to T3 conversion? Yeah, that's often the problem, right? Like I was saying before, a lot of times that enzyme isn't work adequately, or there isn't enough of it, right? Or further down the road, the T3 can't attach to the receptors, and after it attaches to the receptors, it has to transcribe the RNA into DNA and then do like all of the things that it's supposed to do, right? So there's several places along the chain that things can go wrong, where the testing in Western medicine is like all the way back at the beginning of the chain, So if conversion is the problem from T4 to T3, they have to get more T3. Yeah.
What about if conversion is a problem, looking at nutrient status, looking at iodine, selenium, vitamin D, zinc, cleaning up the gut, things like that might enhance conversion?
Yeah, ideally all of that should be addressed, right? Functional gut analysis and that stuff, that's not in my wheelhouse. That's not what I do. Like, I really just focus on the hormones. But if I suspect that there's an absorption issue going on, or there's leaky gut, or there's heavy metal toxicity, or there's some environmental allergy, I usually refer to functional medicine doctor concurrently,
I have done micronutrient testing in the past for people who wanted to do the more natural route and they didn't want to take a medication, they didn't want to take Armour or Nature Thyroid, and they would get benefits on iodine. The only thing with that is it's not really regulated, so you don't really know what other fillers are in it. And so I would always just talk to them about, or kelp, they would take kelp too, and get a benefit from that. But again, it's just not regulated, and so I just would need to disclose that. But that's definitely an option if they don't want to. I just don't do that right now in my practice, but I have seen that and I saw a benefit.
Yeah. And one of the things that we talk about a lot that we've tried to do in our practice, you know, is you know, a protocol is only as effective as you know, as the patient is going to, you know, adhere to it, right? You know, so we really try to keep things as simple as possible. You know, anything that I can do on once a day dosing in the morning, I do. You know, it's like, you know, you tell patients they have to take their thyroid hormone 30 minutes before breakfast and coffee, and like they, you know, flip out. It's like, I don't want to. You know, it's like, so, you know, so what do I do with some of my patients? I say, well, take it anyway. If you refuse to take it, you know, on an empty stomach, 30 minutes before food, take it anyway. We'll see where your level is. You'll absorb some of it. Maybe we have to increase your dose a little bit, but like, you know, we can get what we can get in there, you know. So, you know, it's the reason that I you know, try to keep patients on, you know, 6, 7, 8 things, and that's it. You know, I mean, that even sounds like a lot when it's coming out of my mouth, right? But you know, I mean, I usually can guarantee they will be on many more medications down the road if they don't. You know, because you know, you keep optimal hormone levels in people. You optimize. You know, you keep them at the high end of the normal range, or even in some cases above the high end of the normal range of the hormones you want high, and low end of the range of the ones you want low. You know, I can guarantee you're going to be at lower risk for heart disease, lower risk for type 2 diabetes, lower risk for Alzheimer's disease, lower risk for osteoporosis, lower risk for stroke, and lower risk for cancer. It's been shown in every study, you know? It's like, it's like, and people feel better, you know? It's kind of a win-win.
You mentioned progesterone at the beginning. Do you find that people are usually estrogen dominant? And if you give progesterone, what's the best way? Is the cream, or do you prescribe it very much?
That's a really good question. Do you want to start?
Sure. What you mentioned, the estrogen dominance is very, you know, tricky, and you know, starting it too early, as I had mentioned, can really make somebody miserable and make them retain a lot of fluid, be emotional, things like that. So you do get a conversion if you put somebody on testosterone a little bit to estrogen. So like vaginal dryness is one of the early signs as well. If you put somebody on testosterone, generally that will help with that. If it helps but not completely, they're still having painful intercourse, then you can actually do just vaginal estrogen or vaginal estradiol, so that they're not getting the systemic effects of the fluid retention and things like that. And then the progesterone, balancing it, the old thinking is, well, you only need to give progesterone if you're giving estrogen to a woman that has a uterus. So if you don't have a uterus, if you've had a hysterectomy, you don't need progesterone. That was the old thinking, is that we're only giving it because it helps protect the endometrial lining, prevents endometrial hyperplasia in cancer. But it actually, progesterone has shown to have systemic effects on, and it helps affect a woman's mood, it helps decrease anxiety, it helps with sleep, which ultimately is going to help kind of recharge your system, boost your own production of cortisol, DHEA, growth hormone, all of those things. But progesterone can actually help with, hot flashes and night sweats without the estrogen. And it can actually help with fibrocystic disease, so fibrocystic breast disease, fibroids, uterine fibroids. So I do use quite a bit of it. The
Do you cycle the
transdermal,
progesterone?
I do not. Initially, I did. That was my initial training, but I have found that, I mean, we were born with all of these hormones. We're meant to have them all the time, not just 14 days of the month. And so I give progesterone all throughout the month. I do notice I don't use the cream, especially if they do still have an intact uterus. You don't get the levels, the serum levels that you actually need to protect against hyperplasia. So you actually need to use a pill form. Tissue level, sorry. Tissue level.
And the oral form also is really useful for sleep. It affects the GABA receptors in the brain.
Yeah.
It really works well for a lot of women have major sleep issues. It really helps. I found that good.
Yeah, absolutely. I was going to say, like, I've made more best friends out of women by prescribing oral estrogen. It really is so effective for sleep, you know. Actually, I have to titrate dosing around that, you know. I mean, if I start a woman on 100 or 200 milligrams of oral progesterone, you know, at bedtime, you know, and, you know, sometimes I have to back off because they're feeling so tired in the morning. It's a result of it, but majority of it on 100, 200 milligrams just say that's the best night's sleep I've ever had, you know. And so progesterone's, you know, and some women require higher levels. Some may require 300, 400, 500, even 500, I've given up to 600 milligrams, you know, a day of progesterone to some women. You know, it's virtually impossible to overdose on it. You know, it is mildly euphoric, like Jill said. But you know, if the drowsiness is an issue, then I will sometimes, in addition to the oral, give topical progesterone or a sublingual form, so that they're bypassing first effect and they don't get the tiredness from it.
So progesterone's better to take at night. Is estrogen better to take in the morning? Does it work that way?
Yeah, I dose estrogen in the morning time
Estrogen in the
and
morning,
progesterone at
progesterone at
bedtime.
night.
Yeah, because it helps, especially oral, you know. And the cream doesn't really matter so much, but oral for sure at night.
The other thing that I'll mention, as far as cycling it, I give it consistently throughout the month, but women who are having a regular period, they will get a drop in their progesterone right before, during the PMS stage. So sometimes I'll boost their dose that week before so that they don't have those symptoms. And then I tell them if they feel great on that dose, they can just continue that higher dose throughout the month. The other thing we were talking about a little bit earlier too is women who are not menstruating anymore. They still kind of get a phantom period, or a phantom cycle. They'll still feel like the moodiness or the bloating. And so I do the same thing. If it's just a week out of the month, I just tell them they can take the higher dose during that week. And then if they feel good on that high dose, they can continue it, or they can just drop down to the regular dose.
One of the other things also that I use progesterone for is for reduction of breast cancer risk and endometrial cancer risk in women, and that's especially for women with polycystic ovarian syndrome, because they're at increased risk for both. So progesterone, I immediately put anyone with PCOS on progesterone.
And what do you do for women who have elevated testosterone and their PCOS?
Yeah, well, if there's, I'm sorry?
You don't find a lot of, even in the straight nutritional, there's not a lot of information on how to bring it down. So you're saying progesterone is one of the ways you do it?
Well, that's not going to lower their testosterone. I mean, so PCOS is, we could talk for 3 hours on PCOS, right? It's polycystic ovarian syndrome. It's the most common endocrinopathy in premenopausal women, you know, and it's confusing because it's named poorly. You know, 50% of women with PCOS don't have cysts on their ovaries. You know, when you think of a classic PCOS woman, you think of an obese woman who's got a beard, you know, and you've seen these type of women, this sort of morphology in the market before, you know, whatever, and it's like, oh, PCOS, you know, but 50% of women with PCOS are not overweight, 50% don't have cysts on their ovaries, you know, they have a 50% miscarriage rate in the first trimester, they have a very difficult time getting pregnant, you know. It is a symptom of insulin resistance. That's the problem, is that they have insulin resistance, they have increased testosterone production, which causes an increase in LH and an increase in a decrease in sex hormone binding globulin, so therefore they have increased free testosterone, and so that's why they get hirsutism and acne as well. So in order to treat these women, a lot of doctors will just put them on birth control pills, which will control their menstrual irregularities, but they're not touching the underlying metabolic disorder. And so these women need to be put on metformin, so the mainstay of treatment is weight loss, and then also risk reduction, because they're at increased risk for coronary disease, diabetes, breast cancer, endometrial cancer. So I'll put them on metformin, I'll optimize their thyroid, I will put them on progesterone, put them on spironolactone for hirsutism or acne, and I think what else?
Ketogenic diet.
And a ketogenic diet, a very low carbohydrate diet, right, for weight loss, yeah. But these women fall through the cracks. It's very unfortunate, because it's a life-threatening disease. 50% of women who are not even obese have fatty liver disease. I mean, it's quite something.
Hi, another Chinese herbalist in the room. I reacted to your describing metformin. There are all kinds of studies out showing that berberine is comparable to metformin.
Yep.
Berberine. There's all kinds of formulas out there with berberine. It's really effective. So I want to try that without any side effects.
Thank you. Yeah, I mean, I actually, I'm in love with metformin. I'm in love with her right now. It's like what metformin does is it for anybody who doesn't know, is it's a medication that's been around for hundreds of years. Actually, there's several articles, and lately they're doing a huge national trial on it now for its sort of overall anti-aging benefits, because it essentially protects every organ system, from glycosylation of proteins by sugar. Because what it does is it increases your insulin sensitivity. It sensitizes your cells to insulin so that you can get sugar basically inside your cells faster to burn it for energy. So the sugar, glucose, doesn't hang out in your bloodstream doing damage to all of your tissues, which is what it does. I mean, sugar has a direct effect on your coronary arteries, on your liver, on your joints, on your kidneys. So metformin has been shown to, and it doesn't cause hypoglycemia either, so you don't get low blood sugar as a result of it. So, and also, so I have a lot of, this is like just like, she did me off, because they can also make a topical metformin, because a lot of patients won't tolerate it. It takes some getting used to on the gut, right? So your gastrointestinal system has to adapt to it a little bit. So typically I'll start with one pill with breakfast the first week, one with breakfast, one with dinner the second week, two with breakfast, one with dinner the third week, two with breakfast, two with dinner the fourth week. But some patients will get diarrhea or severe cramping from it. In that case, we'll put them on topical, so they don't have to worry about the gut side effects.
Okay, berberine. You would avoid all of that if you make the exact same effects if you put them on a berberine formula. Exact same effects you just described. It's comparable. It's an herb.
It's not defined. I mean, I agree with you, berberine is really useful.
There are lots of formulas that have other herbs with it. If you're concerned about
Is there a
that.
dose?
I don't think we want to mention particular brands here. If you want to ask me afterwards what I use, I actually specialize in non-pharmaceutical diabetes management, so you're in my wheelhouse right now.
Oh, cool.
And I'm taking all of those patients off of metformin and putting them on this.
But why are you taking them off of metformin?
Well, I'm having their doctor do it. I legally can't do it because I get the exact same effect, and they're reacting to metformin with some of the things you're describing.
What same effect?
And if they've been on it for a while,
What same effect do you
they have some of these, they have GI issues.
But that's a minority of patients who are met.
It is a minority of patients, and it's only in the first couple of weeks. It typically results in
Those are the ones I see because they're seeking
Sure.
someone like me out
Sure.
because they can't take this.
Sure.
So then they find someone like me.
Sure.
So unfortunately, you're right. In my population, it's like a high percentage.
Yeah.
But berberine is fabulous, and I do exactly. There are all kinds of studies out
Yeah,
about it.
true.
Thank you. Yeah.
What dose?
Thank you.
What dose?
Well, I'm using, like this gentleman, I already have certain formulas that I'm using, and then my doses, how many capsules I'm giving.
Got it.
So it's based on their body weight or whatever. And of course, I'm trying exactly what he's saying, some kind of low-carb diet. Not everyone can maintain the ketogenic diet, but some kind of either a paleo diet or a modified paleo, whatever they'll do that's healthier than what they want to do. Okay, so what else is new? But I'm just letting you know there are alternatives.
Yeah, there are a lot of functional medicine approaches to controlling blood sugar and helping with insulin resistance. And, berberine is a well-known supplement that's beneficial. Cinnamon, chromium, there's a whole series.
But you're saying that berberine really has good studies on it.
Yes.
With different things. Great.
Yes,
Yeah,
really
good.
good.
Okay,
And of
thank
course,
you.
there's formulas that have groups of herbs all designed to synergistically work to do exactly, you could have just substituted that formula with the effects that you just described for men.
Thank you.
Could you speak about the connection of the formation of fibroids and the hormone balance? Is there a connection?
A connection between
Formation of fibroids in the uterus and on the uterus?
I don't know that there's necessarily a cause and effect, but I do know that progesterone has been used to shrink the uterine fibroids as well as women with fibrocystic breast disease. So.
I'm going to ask this in a clear way. How long, if a patient has already been in menopause for a few years, what is the latest you will start to get to that?
It's never too late.
So if it's been 10 years?
It's just a
15
matter
years?
of the time frame that you would start oral estrogen. That's the main concern with increased risk for atherosclerosis. If they've gone, one of the Women's Health Initiative was more than 10 years. They had already developed plaque, and then it increased their risk of having an event. So, so even if they've been 10 years out, you can use transdermal estrogen.
And you get benefits?
You will still get some benefit.
Yeah, so what I would do with a woman if she's more than 5 years postmenopausal coming to me for the first time to be on hormones, or has been on them and then off them, right, for 5 years and then back again, so she's initially new to hormones again. So I would assess her for coronary disease, and if she's at high risk or if she has established plaque, then I would use topical estrogen. But if she's at low risk and did a coronary calcium score and it's 0 or very low, then I wouldn't hesitate to put her on oral estrogen. I did that with my mom. She had no hormone replacement for 10 years, and I put her immediately on oral estrogen. She's on it for 8 years. Yes. Yeah. So it's preventative for Alzheimer's, and I think there's been a couple studies recently that actually have shown plaque reversal and oral estrogen. So that's with topical for the Alzheimer's protection, but oral estrogen actually decreases the size of atherosclerotic plaque, right? So there's only 3 things that have ever been shown to do that in studies. Statins don't do it. Testosterone reduces coronary plaque, estrogen, and human growth hormone.
Are you prescribing estrogen? Do you prescribe estrogen? Are you prescribing it by itself, or are you always thinking a little bit of progesterone?
What was the question?
Whether we give estrogen alone or always with progesterone. So that's a great question. You can never give estrogen to a woman who has a uterus without giving progesterone, okay? Or else, because estrogen is proliferative to the uterine lining, and so after time the uterine lining will thicken and she can develop endometrial carcinoma. But if you give progesterone an adequate amount, okay, it will offset endometrial proliferation. And actually, if for a woman who does have a thickened uterus, the treatment choice is progesterone to reduce that. So you should always give them together, especially in a woman who has an intact uterus.
prescribing topical estrogen, would you still prescribe progesterone with that?
Will that cause the endometrial lining to grow? Yes.
Okay.
Yes.
So you do prescribe both, even if it's topical?
100%, yes.
And with that, it's really important to do the oral progesterone to get the tissue levels, because the cream or topical progesterone does not give you adequate tissue levels to protect against the cancer.
Just so you know, I'm not prescribing estrogen.
Well, good.
Any other questions? If not, I think we're going to probably wrap it up. Any final words that you want to say to everybody?
Thank you so much for having us here, and thank you for being so participatory.
So for everybody who'd like to get a hold of you, do you want to?
We love some cards up front.
You want some
Everybody
cards?
can take a card.
Okay,
Yeah.
sounds good.
Yeah, or else it's
Okay.
thebodywellusa.com. We're both on the website. Yeah.
Okay, great. Thank you so much
Yeah,
for joining
thank you
us.
so much.
Yeah.